Hello, Dr. Harima, how are you? Professor Enas, how are you?
Fine, alhamdulillah.
Alhamdulillah, great. Dr. Halima, you are muted maybe.
How are you?
Fine, good. How about you?
Alhamdulillah, everything is good.
Alhamdulillah, very good.
Thank you.
We're getting ready. We still have 5 more minutes, I think, to go.
Yeah. So maybe I can.
So, Professor Enas, you are
Dr.
the first
Halima.
one, I believe. Yeah.
Hi, how are you, Dr. Inas?
How are you? I miss you too much.
الله يخليكي تسلمي يا رب.
Stay home, stay free. Hoping inshallah everything will be okay, yeah?
Yeah, alhamdulillah. Alhamdulillah.
Inshallah. Inshallah.
Alhamdulillah. So we have few minutes.
Dairy or Dairy Nutrition Chair.
Hello.
Yeah, 5 more minutes, I believe.
Hello. Hello.
Good evening, everyone, or good morning, or good afternoon, wherever you are. Welcome to IGD 2021, to this session 5. Today, I am I'm chairing this session. My name is Dr. Harima Ali. I'm from UAE University, United Arab Emirates University in the UAE. Today, we are very fortunate to have 3 excellent speakers who are going to share with us interesting topics, which are also very relevant at this time. So we will start with the first speaker, and which is Professor Enas Rafat. Okay. Brief introduction. Professor Rafat is a principal investigator of different projects with a local or an international, of international and local relevance. She is with the International Clinical Pediatric Nutrition Congress, and she held a number of presentations, and also she holds a number of appointments in various organizations and committees. She's pediatrician and head general moderator of Child Health Clinic. Today, her presentation will be immunity, nutrition and immunity, two faces of one coin, which is this topic is, of course, very relevant considering the current situation which is happening globally, the COVID-19 situation or crisis. So I would like to welcome Professor Enas to start her presentation. This will be about 20 minutes. And if you are gracious enough and you leave a few minutes at the end and you keep it to 18 minutes, then we'll have also 2 minutes for questions and discussion from the audience. Thank you very much. Oh, sorry. Okay.
Yeah, Dr. Enas, you are muted.
Okay, fine, all right. Don't know what happened. The video is not working, okay.
It's a recorded lecture, please. Kim, can you manage the problem?
Baby.
It's a recorded session.
Yes.
Okay, Kim, the team organizers, can you manage this? Because I don't have that.
Good afternoon, everybody. It's my honor to be here with you, sharing your highly scientific first conference of international growth and development. Many thanks to Professor Aisha Tahri and Professor Laila Al-Sheikh to offer me this chance to be with you. My talk today will be about nutrition and immunity and how they act to be two faces of one coin. Window of opportunity, as we all know, it's the first 1,000 days in the life of the baby. Here, start maturation of the infant immunity, modify the goal of potential immune programming, establish adult immune system maturation. The development of the immune system is started as early as the yolk sac during embryogenesis to start both the innate and the adaptive immunity. Thymus, by the 7th week of gestation, started the development of the T lymphocyte, while bone marrow, by the 20th week, began to develop B lymphocyte and monocyte. What are the factors that affected the development of the neonatal immunity? Genetic predisposition and maternal factors. There is a multiple of factors of the maternal, on top nutrition, stress, or environmental exposure, but no one can say that no single factor can predict all act together to alter the immune status, not only one. How can the maternal impact neonatal immunity? The mother offers her baby two parallel pathways passing together, the microbiome development and the immune maturation. Both are parallel, go together till end with the end of the GIT immunity maturation at around 3 to 5 years, as we will say soon. The maternal impact for the microbiota will start from prenatal, natal, and postnatal period. The prenatal factors start from the gestation by the placenta, passing through the neonatal factor with the mode of delivery and the gestational age, to the postnatal factor to add type of feeding, breastfeeding or formula, maternal diet, weaning, and so on, to end at the toddler and the childhood around 3 to 5 years by a maturity of the gut microbiota. Is there a rule for the timing of maternal nutrition on neonatal immunity? Yes, for sure. Maternal preconception nutrition will act for the immune programming, while nutrition in the first trimester will attack the immune cell rapid proliferation. Nutrition during lactation period lead to the development of lasting and significant maternal nutritional insult during pregnancy or lactation will result in an alteration of the long-lasting neonatal immunity program. How can this programming occur? The first of all, nutritional stress. If it's occur, it will activate the maternal hypothalamic pituitary adrenal axis. In response, fetal exposure to such elevated stress hormones lead to permanent changes in the neuroendocrine immune interaction with attenuated brain-gut axis. Maternal malnutrition, if happen, have a direct influence as evidenced by nutrient-driven epigenetic changes to the developing T-regulatory cell in what's called the nutrigenomics. The third programming pathway is a passive placental transfer of maternal immune factors with immunomodulatory functions via the umbilical cord of the fetus. In Hari, what is the nutrigenomics? This is the effect of the nutrition on the gene. If we take just an example for a healthy food by this green vegetable broccoli, it passed through this green pathway with the epigenome, transcriptome, proteome to end finally in a healthy physiological state. While, for example, if we take this red pathway, which is represented by a junk food, it will end at the end by what's called metabolome. The metabolome is responsible for oxidative stress, metabolic stress, inflammation with neurological stress, ending by a disease. So let's say how is the neonatal microbiome is formed. This neonatal microbiome is the result of adding 3 factors together: feto-maternal microbiome, immunogenetics of the newborn, peripartum environment. They will add together to form the intestinal microbiota of the newborn. The intestinal microbiota is affected by different factors: duration of gestation, mode of feeding, mode of delivery, environment, and medication. According to which the intestinal microbiota either to be directed toward the symbiosis, that's to say immune tolerance, intestinal homeostasis, and healthy metabolism, or this directed toward what's called the dysbiosis, which means immune disease, intestinal disease, or metabolic diseases. So the question is now, how can the maternal microbiota reach the fetus? It can reach the fetus through the placental barrier. Here we can find they are so close to each other, the placental decidua, with the chorionic villi carrying the umbilical veins and arteries, so they are in close contact, or through the blood, or oral microbiota of the mother can reach the placenta through the blood. What's the relation between infant microbiota development and the adult immune system maturation? We have to know that. Neonatal microbiota colonization is initiated during intrauterine life. The adult type of the microbiota is reached at age of 3 to 5 years. Long-lasting immune response then is produced. So, what's the direct effect of nutrition on immunity? Nutrition establishes the immune system through normal organogenesis, adequate immune response through the normal proliferation of the immune cell, well-formation of the placenta in what's called placentation. Consumption of the prebiotic containing food may reduce childhood allergic disease. High-fat maternal diet alters the offspring microbiome. And finally, micronutrient supplementation to maternal diet can alter fetal immunity. So, how does the nutrition affect the gene, or what's called the epigenetic factor? The nutrition, we have to know that it affects only gene expression, not the gene sequence. affecting the phenotype and not the genotype. This occurs through two pathways or two effects, either a direct effect via the DNA methylation, histone modification, chromatin remodeling, or microRNAs, or the indirect effect through the microbiome itself. The relation between nutrition and the immune response is well documented in multiple publications. This one and the new one in the 2017 state that the members of the maternal microbiota can metabolize dietary compounds, which can subsequently pass to the developing fetus or breastfeeding neonate. We have to know how the maternal-fetal immune system interaction has to occur. This interaction occurs in 3 successive steps. 3 or 4? No, only 3. If they occur in the same sequence, it's okay, the immune system will be very well developed. If they fail, a failure will occur, as we will say. What's meant by the first one is the recognition. Maternal immune system develop immunological tolerance against fetal placenta antigen derived both from the placenta and the maternal genome. Then, activation of the maternal immune system will produce protective immune regulatory mechanism for the development of the fetal immune system. Then the third one is the trafficking, which is a bidirectional transplacental feto-maternal cell throughout the whole pregnancy for activation of the immune pathway. If these 3 steps are not continuously followed, failure of the maternal immune activation will increase the pro-inflammatory cytokines with increased risk of atopy later on. So, what's happened during pregnancy as regarded the microbiota? As regard the microbiota and regard the immunity. The maternal T helper 2 will instruct the fetal inflammatory immune pathway. In response, the infant will stimulate T helper 1 activity, restoring balance of the T helper 2 cell. Thus to say, the T regulatory population will suppress the overall inflammatory process. If it fails, it will result in a neutrophil infiltration of bronchial asthma, to smooth muscle hyperplasia, eosinophil hypersecretion, atopic pathway in the newborn. So, how can the nutrition boosting the immunity? It can do so through micronutrient effect, nutraceutical effect, probiotics. And the micronutrient, we have to know that it includes the vitamin and the trace elements in the maternal diet. So, we have to focus on the role of the maternal nutrition of the pregnancy and the lactation. As regard the macronutrient, firstly, we have to talk about the protein. The amino acid of the protein will regulate the activation of T and B lymphocyte, production of cytokines, regulate gene expression for immunity. Also, the carnosine, which is a bioactive peptide derived from the amino acid in the meat and fish, result in modulation of the immune system and increased production of interleukin-1B. Second macronutrient is the fat, L-alcipophos, or what's called long-chain polyunsaturated fat acid, is responsible for the gene expression and signal transduction and provision for chemical mediators. Third, we have the carbohydrates, which is a key role in the immune response for the lymphocyte, macrophage, and the neutrophil. Also, the galactose involved immune system, both innate and adaptive immunity. As regards the maternal micronutrients, the pregnant mother needs iron, zinc, selenium for efficient neonatal immunity. She also needs probiotics to fortify gut barrier to modulate immunity. She needs prebiotics to stimulate the growth of commensal microbe to protect infant gut. This will lead us to what's called the nutritional education for the pregnant woman. Awareness, we have to tell her about awareness for the role of nutrition in the first 1,000 days. Focus on the role of nutrition for the immune modulation. Avoid any nutritional insult to protect immunity. Nutritional counseling for an infant and the mother. Antenatal parental classes are mandatory. Okay, we finished the pregnancy, the mother eat well, we have to start lactation, breast milk. Breast milk microbiota educate the infant immune system to shift the intrauterine T helper 2 to helper 1, stimulate two regulatory cells to overcome the harmony, the balance, modulate natural and acquired immunity, and shape his own microbe. We have to say that the breast milk contains its own microbiota, train the naive immune cell, establish gut colonization, and it contains the gene traits with the immunity memory. Breast milk immunity have its own transfer of already formed immunoglobulin or anti-inflammatory substances. The frontiers in 2019 stated that the breastfeeding shaped the gut microbiota in early life, both directly by exposure of the neonatal milk microbiota or indirectly through maternal milk factors such as human milk oligosaccharides, secretory IgE, and different factors. As we all know that only one drop of breast milk have all of these. We cannot enumerate the benefits of all these, but just we have to mention an example. The human milk oligosaccharides is a complex carbohydrate, high concentration in the breast milk, 5 to 20 grams per liter. Its fermentation results in short-chain fatty acid, which is the energy source to the colonocyte. HMOs help in shaping the infant microbiome generally. Another one is the bioactive protein like lactoferrin, which is the chelating factor for the free air for bacterial nutrition inhibiting their growth. The lactoferricin, which is a partial digestion of the lactoferrin, it attacks bacteria and virus, stimulation of the pathogen and phagocytosis, promotion of beneficial gut microbiome. Another example of the glycosylated protein or mucin-1 is very important to know that the mucin-1 is one of the multiple factors around only fat drop. The drop of the good stuff contain different factors like the mucin-1, which act to prevent pathogen adherence to gut epithelium, inhibit binding of the H. pylori and rotavirus to gut mucosa, decrease the rate of acute GIT infection. This will lead us finally to the nutritional education for the lactating mother. We have to say that the quality of diet is as important as quantity. Micronutrient supplementation is mandatory. No skimmed milk during lactation is allowed. Fluids is needed. Good balanced diet is a must. Colostrum, even non-visible drops, it is enough. Don't stop lactation at any circumstances, even on the time of inflammation. We have to conclude by maternal adequate nutrition with micronutrient supplementation is mandatory for immune system programming. Also, maternal-fetal interface during pregnancy will play a central role for future adult immune system maturation. Maternal immune component through breastfeeding shape and protect the immune regulatory mechanism of the infant. To wrap up, child immunity is affected by several perinatal factors, is influenced directly by maternal nutrition, is guided by breast milk microbiome, is trained until maturity by the maternal immune cell. And thank you very much.
Thank you very much, Dr. Enas, for your excellent presentation. You have shared with us in how to build the immunity of the mother, not only the mother, but also for her baby. So thank you very much for this presentation.
Thank you.
Our next speaker is Dr. Harima. So we are very fortunate today to have our next speaker as Dr. Harima Sabah. So Dr. Harima is an associate professor and a former chair of the Health Sciences Department at Said University here in the UAE. She has her PhD in public health and nutrition. And also Dr. Salah was a Fulbright scholar, senior visiting scholar, where she did her postdoctorate studies at Tufts University in Boston from 2011-2012. Dr. Sabah is a regular invited guest speaker in scientific conferences in different countries and different continents. Today, her presentation will be Exclusive Breastfeeding and Complementary Feeding Knowledge, Attitude and Practice, KAP, and it is determined in Dubai and Sharjah. Let's welcome Dr. Harima. Thank you very much, Dr. Harima. You may go ahead and proceed with your presentation.
Thank you very much, Dr. Habiba, for this nice presentation. Thanks to Dr. Aisha, the chair of this conference, and Dr. Layla and Kim and all the organizers of this conference also. Every year we participate in this conference that it's supposed to be last year. Unfortunately, because of the corona, it started also, it postponed till today. And before 3 years, it was in the same date like here. So today I will do a presentation about breastfeeding and exclusive breastfeeding in Dubai and in Sharjah. This study, I have done that from a grant from my university, Zayed University, and Dr. Hadia Radwan from Sharjah University was also co-author of this research. So I want to share my presentation. Let me share. Just Kim, can you allow me to share, please? Okay, thank you so much. Okay. So to start my presentation, as I mentioned, it is about exclusive breastfeeding, formula feeding, and the practices among women in Dubai and in Sharjah. So to start my presentation about the introduction. So, sorry, just a moment. So all of us, because most of us are health professionals, and we know what does it mean by exclusive breastfeeding, and the definition by the WHO that exclusive breastfeeding, it means that it's only breast milk, including expressed also breast milk, and allows the baby to receive also vitamins, minerals, or medicine according to the WHO definition. And exclusive breastfeeding now, it is also defined to be also, and it is put by the WHO to be 6 months in order to be effective intervention for the infant and to survive. So according also to the recommendation from the UNICEF and from the WHO, they changed, because before it was 4 months to exclusive breastfeed the baby, but now after they saw the effectiveness of this of the exclusive breastfeeding on infant survival, also in infant immunity, they put that they recommend that exclusive breastfeeding should be to 6 months. So also they encourage the initiation of breastfeeding in the first hour, and also because it has an impact also on the infant exclusive breastfeeding and also on his health. So breastfeeding continue along with suitable, safe, appropriate, and adequate complementary food up to 2 years, according also to the WHO and also to our Quran, also who encourage us also to breastfeed the baby for 2 years. Why do many women not choose to practice breastfeeding, although we have numerous benefits of breastfeeding? So sometimes they said that our literature found that there is lack of knowledge among these women and they need more information or awareness programs. Also, lack of confidence, lack of self-efficacy. They don't have a self-efficacy. They are they think that they are not able to breastfeed their baby. Also, personal choice or body change. They thought that maybe their body will be changed and their body will be not nicer like before. And lack of support from the family, from the husband, sometimes from the friends. Also embarrassment. Many women also, they feel shy, and in order if they want to breastfeed their baby in front of others. Also the busy women or the busy mothers who are working and who are studying. In one of the recent studies that have been done recently also by Al-Shahwan about the most common reasons to wean the baby or to stop breastfeeding the baby in UAE, and he found that 35% of these women, they discontinue to breastfeed their babies. And the main reasons were that the low milk, pain or congestion and abscesses, and also they get pregnancy while they are breastfeeding their babies. These were the main reasons with other reasons. So practice of breastfeeding, it is contributed to many factors. One of these factors is the education and also the occupation of the mother. So education, the more educated mothers in some of Arab countries, and in the literature, they found that they have less less likely to exclusively breastfeed their baby because also they are working and maybe they have other obligations and other commitments. And those who deliver by cesarean section, also they were less likely to breastfeed their baby, according to the literature. And lack of understanding about the importance and the significance of exclusive breastfeeding for the 6 months among rural mothers in one of the studies. Sorry. Okay. So the decision to breastfeed or formula fed is based on woman comfort level, lifestyle, and also specific medical conditions or considerations that they might have. So what was the significance or the importance of this study? First, maybe there was insufficient knowledge. Insufficient knowledge always leads to unfavorable consequences. So the key also successful breastfeeding is knowledge. So the education is very important. Education of the mother is very important. Awareness is very important. And education and communication strategies aimed at behavior change. So as I mentioned earlier, that Islam also encouraged women also, according to the Quran, instruction to breastfeed their children for 2 complete years. So there was also limited research done in UAE that described the knowledge, the attitude, and the practice of breastfeeding and complementary feeding in the UAE. So here also there is one study by my colleague, Dr. Zainab Taha from Zayed University, who did a study about also breastfeeding practices among infants and young children in Abu Dhabi, but not in Dubai and in Sharjah. So it was in one of the Emirates in Abu Dhabi, and she found that 95.6% of the mothers initiated breastfeeding and 59.8% initiated breastfeeding within the first hour, which is very good also percentage that she found. And also exclusive breastfeeding among the infants aged from 0 to 6 months, also it was 44.3%. So UAE is also in a good, or in Abu Dhabi, good results about breastfeeding maybe. So, but maybe if we go through the articles, maybe they are also center-based or it's not community-based. Also here about complementary feeding, another recent study with my colleague, she found that also 938 out of 1,822 participating women, they do also initiated complementary feeding for their children. So how can this study be useful to the participating institutions and in the UAE? First, understanding the population of childbearing females better and based on the results, interventions can be planned effectively to target the barriers to breastfeed. So we can do a good planning or good healthy promotion programs for that. And also results will provide solid basis for planning for healthy promotion programs as mentioned, if we have some information or baseline information. Also results will help to improve the health of the babies in the UAE and make it also easier to promote baby-friendly environment. The main objective for this study was to assess the prevalence of exclusive breastfeeding and to identify also the main contributing factors to exclusive breastfeeding among infants aged from 6 to 24 months in the Dubai and Sharjah. This is in order, the purpose of that is in order to improve the public knowledge about breastfeeding in UAE. Regarding the methodology, this study was a cross-sectional study in both Dubai and Sharjah as mentioned, and we used 800 women participated in convenience sampling methodology, and also we use the consent form before data collection that the mother also volunteered to participate, and also we have trained interviewers who are collecting the data from our students. We train them in order to collect the data from the waiting areas of the centers and hospitals. So based on the last child experience of who aged 6 to 2 years. And the interview, it takes about 10 to 15 minutes. This is also the consent form that the woman also agreed on to participate if she wants to agree on or not. And these are also the settings or the health centers and the hospitals that are also agreed or we selected them for this study for hospitals and for health centers. So these hospitals and health centers, 4 in Dubai and 4 in Sharjah. I have to sometimes to do the pictures above. Okay, so we have 400 from Dubai and 400 from Sharjah, from Latifa Hospital, Dubai Hospital, Al-Mizhar Health Clinic, Al-Mankhul Health Clinic, from Sharjah, Al-Zahra Hospital, Al-Qasmi Hospital, Rikka Health Center, and Al-Khaldiyah Health Center. So the criteria or the selection criteria for the sample, we select that all those who are available in the waiting area and who agreed to participate in the study, those who are Arab women and having at least one child, aged also 6 months to 2 years at the time of the study. Also, the visitors to these only hospitals and clinics. Of course, we face challenges and limitations like any other study, but the most important challenge was the ethical approval. It was not easy to get the ethical approval, especially from the MOH and the DHA, and it delayed the data collection for this study. So we have to collect the ethical approval from 3 institutions, from the first from the university, Zayed University, second from the MOH, and third from also the DHA. So also we have missing data because some of the information are missing. Some of the participants, they refuse also to participate because they don't have time. They said that they have to go home. And also low number of participants because of the selection criteria. So this is also, as mentioned, that this study or this research was funded by Zayed University in a grant, we call it RIF grant or Research Incentive Fund. As mentioned, we got the ethical approval from the university for data collection, from the Ministry of Health, and also from the DHA. So 3 institutions approved this study in order to collect the data. So the results, I will select some of the results in order to present here. We found like there is an association between the Emirates or the location of the participants, or although in the literature they found significant difference between breastfeeding and cesarean section, but in this study we don't find a significant difference. But the interesting findings that 30% of the participated were about 1/3 of the participants. Because of that, I'm always like to do normal delivery more than cesarean section, because in some countries they encourage, like in my country, for example, in Palestine, I remember I was working in a hospital and they were encouraging for cesarean section for the woman. They give them articles and they thought that it is benefits for the woman, but it's just to have more money when, okay.
3 minutes to go.
So the menstrual cycle, stop the menstrual cycle, it has also significant difference. Here also contraceptive use, it has significant difference with the mixed feeding, and also the menstrual cycle, it has also significant difference. In conclusion, that mothers have a higher prevalence rate in practicing exclusive breastfeeding, and exclusive breastfeeding is associated with contraceptive use and also menstrual period and breastfeeding during the first hour. For listening and for your presence, and hope that you enjoyed the presentation. Thank you so much, Dr. Habiba.
Thank you very much, Doctora. We enjoy this presentation, and every time you present, there is something new. So thank you very much. So we will go to our last speaker, but not the least speaker. So our speaker is Ms. Massoum Al-Jasmi. So Ms. Massouma is a graduate of UA University, which is our college actually. And she worked as a dietitian at Latifa Hospital, where she provided counseling to both adults and pediatrics, and in both acute care as well as outpatient care settings. Today, her presentation, she has joined the Al-Jalila Foundation, Al-Jalila Children's Hospital, as the head of the clinical nutrition section. Today's presentation from Ms. Massoum is the dietary management for newborn diagnosis of classical galactosemia. We welcome Ms. Massoum to the presentation. Thank you very much. Please go ahead and share your presentation. I believe it's the, you're muted.
Yes. No.
Okay,
Assalamu
thank you.
alaikum. Good evening. Thank you, Dr. Habiba, for introduction. And I would like to thank Dr. Asha Dhahri to invite me to International Growth and Development. Today, I would like to talk about the dietary management, the classical galactosemia. It's not move. Okay. So, my objectives to make the audience more familiar with the galactosemia and the clinical presentation, highlights over the dietary treatment and the nutrition intervention, including food allowed and not allowed, emphasize on the importance of the calcium supplementation, vitamin D supplementation, also to provide the hints, tips, and the take-home messages. Through my presentation, I will cover introduction, overview of the galactose metabolism, dietary management of classical galactosemia, recommendations, and last conclusion. So, what is the classic galactosemia? Is a group of the rare metabolic disorder characterized by impaired galactose metabolism, can be fatal and life-threatening during the newborn period. Galactosemia is autosomal recessive disorder, meaning a child must inherit one defect in gene from each parent to show the disease caused by deficient or absent activities of one of the three enzymes involved in the galactose metabolic pathway. Galactose, as we know, it is the simple sugar. It's normally found in the liver before being used as energy. Classical galactosemia that we will consider about it today, it is most common and the severe type of galactosemia. Dietary management for the classical galactosemia, it is essential and important, as the galactose restricted diet resolves the sign and the symptoms of galactosemia. Incident. According to the National Organization for the Rare Disease, galactosemia affected in one in every 40 to 60,000 newborn around the world. So, as we said, it is a rare inherited metabolic disorder of carbohydrate. If the parents, both of them, they are carriers, the chance to have the patient with the children with the galactosemia is 25% in each pregnancy, and this is due to the GALT defect in chromosome 9. Physiological mechanism. The clinical manifestation of each enzyme deficiency is different. For example, in the patient with the GALT deficiency, which is the classical galactosemia, potentially later and demonstrates long-term organs specific complications. Organs affected: kidney, liver, brain, and eyes. Okay. A little bit, in brief, we will talk about the galactose metabolism. Galactose, it is metabolized by lactose simple sugar through the linear pathway, and it involves the three enzymes, which is the glucokinase enzymes, which is transfer the glucose to glucose 1-phosphate, and the galactose 1-phosphate uridyl transferase, which is transfer the glucose 1-phosphate to glucose 1-phosphate. Then to glucose 6-phosphate, which is leaded to glycolysis and to complete it the produced sugar for energy or glucose for energy. Through the digestion, the lactose is divided to galactose and glucose. Lactose binds with the enzymes GALT and completed to produce the glucose, which is energy for the body. In cases of, when in condition of galactosemia, which is enzyme, it is not available, accumulation of the galactose in the blood lead to health problem. Type of the galactosemia, we have 4 types of the galactosemia. GAL deficiency, which is, as we said, it is the most severe form and most prevalent, it is 95%. The calc deficiency, milder form, 5%. And the Kali deficiency, it is rare. Calm deficiency recently reported a novel type of the galactosemia. As we said, the classical galactosemia, it is because the defect genes galactose 1-phosphate uridyl transferase. The normal, this is enzyme, it is have and no any deficiency. The normal process for the normal level cells, but in case we have the defect on this enzymes, mutated liver cells and lens cells. Okay. The type of the classical galactosemia, we have the 2 types of the classical galactosemia: complete deficiency of the GALT classical galactosemia. This is have the less than 10% of the enzymes, which is not enough to prevent the sign and the symptoms of the galactosemia. Partial deficiency have the more than 10% that to be working nicely and to avoid the sign and the symptoms. The sign and the symptom of the newborn, which is appear within a few days after the birth and after the baby gets the milk, breast milk, which is include the poor feeding, vomiting, diarrhea, jaundice, poor weight gain, lethargy, irritability, seizures, and hypoglycemia. Complication, unfortunately, the galactosemia, we cannot avoid it long-term complication due to the endogenous lactose. Early deduct and the implementation of the dietary treatment failed to prevent long-term complications such as cognitive and ovarian impairment. The complication with the galactosemia, it will be cataract, cirrhosis, sepsis, delay speech development, severe mental retardation, premature the ovarian failure in the woman, and poor intellectual function. Diagnosis through the newborn screening for the galactosemia is common practice. Blood taken from the heel pack. There is three kind of the test, either it will be through the blood test, urine analysis, or molecular test. What is the goal of the nutrition support? Our goal to support the normal growth and development in the children. We have to maintain the normal growth nutrition status, maintain the normal GAL 1-phosphate concentration, and also to prevent long-term complication. Dietary product, for sure, we have to stop all the food that contain lactose, and we started the soya-based casein, hydrolysate, or the elemental formula for infant. The main source of the galactose is lactose, so all the lactose is excluded from the diet. Dietary management, it will be lifelong. New diagnosis infant. Immediately, when we diagnose the patient with the galactosemia, we have to stop breastfeeding or normal infant formula and substitute by lactose-free formula suited for the galactosemia. And we have to maintain the blood GAL 1-phosphate level below 2 milligram per deciliter. Galactose restricted diet should be keep it blood GAL1 phosphate at a safe level. Patient with the galactosemia, they needed very closely monitoring. We have to monitor growth rate regularly, evaluate the blood GAL1 phosphate weekly till 6 months, and the monthly above the 1 year. If the GAL1 phosphate more than 2 milligram per deciliter, we have to check the diet history of the patient and evaluate for the galactosemia intake, long-term monitoring of the neurology and the endocrine status. What is the types of the food that contain lactose? As we know, lactose is found in the 3 main food types: dairy product, like cow's milk, product made from the milk, manufactured food that contain milk. Cow's milk include the pasteurized, full-fat, semi-skimmed milk and skim milk found in the breast milk and animal milk, such as cow's chips and the goat and the camel milk, fresh or dry milk. Also, we found it product made from the milk, like milk, yogurt, cream, cheese, butter, ice cream, milk powder, ghee, whipping cream, buttermilk, curd, milkshake, cookies, milk sweet. All of this product contain the milk. Manufactured food that contain milk. Milk may be added to manufactured food in the many form: lactose, whey, or casein, or animal fat. Milk protein such as whey and the casein or the milk fat will have the some lactose attached to it. So all the sources of the milk must be avoided. It is important that all tinned or the packaged food is checked to see if it is contain milk or any kind of form of the milk. Other source of the galactose to be avoided: pulses and the legumes, and also the organ meat. Pulses and meat like the garbanzo beans, lima beans, kidney beans, lentils, fermented soya product, organ meat like liver, kidney, brain, sweetbread, and heart. Also, some heightened source of the galactose. Galactose may be act as the carrier for the flavorings, chips, and the other salty snacks, but this may not be identified on the food label. Tablets and the medication. Also, some tablets may contain the lactose for the or the bulking agent. Capsule and the syrup are not usually problem, but still we have to check if added lactose or not. Endogenous galactose, this is that make the dietary management for the galactosemia is very difficult, or it is not prevent to get it the complication, long-term complications. The endogenous galactose to the galactose that is normally produced by the body. The endogenous production is strongly age dependent, with the highest production in the newborn, which is the more than 25% per kg per day, decreased to minimum 8 to 4 milligram per kg per day in adults. If we see in the figures that it is showing in front of us, the typical diet, which is including the 2 cups and the 3 serving of the fruit and the vegetables with galactose content, more than 20 milligram galactose per 100, it is contain galactose more than 12,000. Approximately amount of the endogenous galactose produced by adult with the galactose, it is more than 12,000. And the galactose content of the typical galactose restricted diet include 2 cups of fruits and the 3 vegetables. It is lactose content more than 20 milligram per 100. It is around, it is less than 2,000. So the endogenous galactose, it is very contribute and affected with the classical galactosemia. How to read the food label for the galactosemia, the name, we have to check the name of the food, a list of the ingredients or the processed ads that cause allergy or the intolerance. Mandatory food information must be easy to see, clearly legible. Checking the list of the ingredients for the milk, we have to check if it is safe or not safe. If it contains any kind of the source of the milk, for sure it is not safe and not suitable for the patient with the galactosemia. What about the labels that say may contain milk? Some food may have, it is milk-free, but the label says that the phrase such as made in factory where the milk products are made may contain the trace of milk. There is a risk of the contaminations. This kind of the product, it is specific for the milk allergies, and as the galactosemia is not an allergy, then this food will be safe to people with the galactosemia to consume. Unaccepted food ingredient which is contain the lactose, like the butter, non-fat milk, non-fat milk dry, buttermilk, cream, milk chocolate, cheese, buttermilk solids, non-fat dry milk. All these ingredients is not accepted. On the other hand, the accepted food ingredients, lactic acid, sodium lactate, potassium lactate, sodium lactate, it is safe to consume by a patient with the classical galactosemia. Allowed, all the fruit and vegetables, some fruit and the vegetables do contain a small amount of the galactose. If the fruit and vegetables that contain less than 25 milligram per 100, it is allowed and safe to eat by the patient with the galactosemia, and also the food additives, sodium or calcium caseinate in the diet for galactosemia. Although the higher in the galactose, all fermented soya-based products can be allowed in the small quantities that are typically used in the diet. What is the formula that we give for the patient with the galactosemia? It's important to replace the normal milk with the lactose-free milk substitute, especially in infant and young children. Common formulas used for the infant with the galactosemia is soya protein isolated. This should provide the calcium and other important nutrients necessary for growth, for the healthy growth and development.
Can you conclude, Dr. Massoum, so that we have a couple of minutes for questions?
Okay.
Thank you.
Okay, this is the formula that we can use it. Just I will go past quickly. The weaning, we have to start it in the usual weight, and we have to check for the ingredients. We have to not go to the name of the items or the product. We have to check if it is contain the galactose or not. And we have to encourage the patient to have the rich food and the calcium and vitamin D. This is some substitute for the younger children and adults. The milk substitute to avoid anything that it is have added the lactose, whole soya beans, caseinate, added the lactase, soya beans, and soy protein. This is the Galactosemia diet with the food group, allowed and not allowed. Important to supplementation with the calcium. In galactosemia patient, children are dependent on the obtain most of their calcium from the infant soya formula or the soya drinks fortified with the calcium. A small amount is obtained from the soya dessert. If the children are only taking the small quantities of the milk substitute, calcium supplemented is recommended. It is difficult to achieve the adequate calcium intake on the low galactose diet. It is highly recommended to provide calcium supplementation for the children with the galactosemia. Recommendation, immediately we have to start the lactose-free if suspected the galactosemia, and we don't have to waiting for confirmation of confirmation of the diagnosis. Also, the elemental formula, it is the best options for the galactosemia, but it is expensive, and there is no evidence that the consuming elemental formula provides a clinical benefit for the infant with the galactosemia. Long life galactose restricted, we have to go to the galactose from the dairy product, but it is allowed galactose from the non-milk source that contribute minimal dietary galactose.
Okay, thank you very much. We are all run out of time now. Can you conclude in 30 seconds? Thank you.
Okay. Hydrolyzed formulas, it is suitable for, it is have the medium chain fatty acid, and it is significant, it is suitable for liver disease. Free lactose, suppose all the foods that have the lactose, but if it is less than 25 milligram, we can give safely for the galactosemia patient. Recommendation, calcium and the vitamin D. Things, and we have to remember this, the tips. Food label should be read carefully. All lactose contain food should be avoided. Avoid the organ meats. Medicine should be checked. Dietary restriction continue through the life. Conclusion: the diet, it is the diet plays an important role in the treatment of the galactosemia. If placed on the lactose and the galactose restricted diet, the symptoms quickly resolve it, and can be prevent the permanent damage. With the continued dietary management, many individuals have good health and are able to live safety. Out can be dependent on the gut activity, age at the diagnosis, and compliance with the lactose intolerance, lactose restriction. And this is the support group and my reference. Thank you for your attention.
Okay. Thank you very much, Massoum, for this interesting, very interesting presentation. I'm sure the audience have enjoyed all the three presentations, and this time I would like to thank all of you, Dr. Enas and Dr. Harima, as well as Ms. Massoum. And now we will take some questions from our audience. So we will start with one of the questions for Dr. Harima, which is why cesarean women are less likely probably to breastfeed. Dr. Harima.
Yeah, thank you for this question. That it's according to the literature and also to be logical, it's the positioning when you position the baby. It's very painful, and it's not easy for the mother with cesarean section to do that, especially at the first hour of the delivery, or first hour of compared with the vaginal birth, of course. So the positioning of the baby is difficult, it's painful. So less breastfeeding than those with vaginal birth. I hope that I answered the question.
Okay, thank you very much, Dr. Harima. For Massoum, the question is, okay, this plan for that you will give to the mother will be very challenging for them to follow. So, and how do you ensure that you will have a longer term adherence or compliance with this kind of plan, especially since it's difficult for the mothers not only to avoid milk containing lactose, but all products that may contain, any milk product. So what do you do? And what is the success rate that you have so far?
Dr. Habiba, we have to continue with education for the parents. And the young children, it is difficult, but still we have to educate them, and we sit with them that which is allowed and which is it is not allowed. It is very big challenge. Really, it is not easy to to avoid, especially when the children, they will go to the school. It is difficult to also to avoid some food that we don't know it is hidden of the lactose and galactose. And especially in our countries, it is the ingredients, it is not clear to know it exactly it is have or not have. But still, we have to continuous education for the parents to avoid it, the children to get it kind of the lactose in the diet.
Thank you very much. There's also one question from the audience to Dr. Massoum. It says, galactosemia, do we need to follow this diet restriction only for first year, or there's no need?
No, we have to
I guess
follow.
you already answered that in your presentation.
Yes, we have. It is long life diet. It is genetic metabolic disorder. It is not just allergy or any kind of the tolerance. It is the metabolic disorder disease that we have to follow the diet long time, long life.
Thank you. One question I may have for Dr. and us is that, okay, you spoke about the importance of certain micronutrients, iron and zinc and so on, the immunity for the mother, for the babies eventually. But if the mothers are not getting those micronutrients, as research have shown, what do you think is going to happen to their babies? Do you think they will be at higher risk, or they to have some impaired immunity? Or what's your opinion?
Thanks a lot, Professor Habiba, for your moderation for all the discussion. Yes, for sure. It's just we were in a hurry for the time. There is a multiple of research and work on the effect of the micronutrient supplementation of the mother and their effect on the immunity of their babies. It's a very link between them. That's why supplementation for the mother is now mandatory. Each trimester need a special micronutrient more than the other for the baby. The range of the consequences range from either defected immune modulation of the baby up to some defects in the birth outcome at all.
Thank you very much. Let me check if there are final questions from the audience. Okay, this is for, I believe this is for Massoum. Should the parents do a blood test to check if they have any genetic problem of galactosemia before they get married?
I am not sure if it is showing that the patient with the classical galactosemia show in the blood test, but we have the newborn screening. Through the newborn screening, we can detect it that the patient have galactosemia or not.
Okay, thank you very much.
I think that's it, Dr. Habiba. Our next session will start in 2 minutes. Before we would like
I would like to thank all our speakers, all the three of you, Dr. Enas and Dr. Massoum and Dr. Harima, for your presentation. And we thank you, and hopefully we'll see you again in the next year, IGD 2022 and beyond. Thank you.
Thank you so much. Before we leave, everyone, can I require everyone to look at your camera and take a screenshot? All right. In 3, 2. Okay. In 3, 2, 1. Look at the camera and okay. Thank you so much. Thank you so much to the four of you.
Thank you.
Thank you.
Hello? Hello?
Hi, Dr. Fatme.
Hi, how are you, Cam?
I'm good. Thank you. How are you?
I'm
How are
fine,
you?
thank you.
How are you,
Fine.
Kim?
Hi, Professor Senna. How are you doing?
I will kill you when I see you. This is a secret.
I hope to see you soon.
There is a secret between you and me later on.
Yeah.
Dr. Sana, I'm a witness.
أيوة. طب thanks God no problem. I have no problem. ترفض.
كيفك دكتورة؟ Nice to
أهلا حبيبتي أهلا بيكي.
الله
Nice to
يسلمك
meet you.
يا رب. It's a pleasure to be moderating the session that you are going to speak in.
The pleasure is mine,
And
حبيبتي.
to meet
Thank
you.
you so much. Thank
الله
you.
يسلمك.
Hope next time we will meet
face to face.
live. Yes.
Exactly. Anna, unfortunately, this is the only because I also organize the Vitamin D conference every year, and it happens to be exactly the same time of that conference. So this is my first year really being able to participate.
We hope you participate more and more next year,
Inshallah.
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 And we will participate with you for the vitamin D. We have a lot of vitamin D for children. أهلا بيكي حبيبتي. أهلا بيكي.
تسلم يا رب.
Shall we start, Dr. Fatme?
Yeah, sure.
Shall I start my slideshow? Well, not yet.
We can start, Kim?
Yes, Dr. Fatme. It's okay, Dr. Sanan. Dr. Fatme will start to introduce.
I will introduce, yeah. Hello, everyone, and welcome to the session 6, which is a very interesting session. I would like to welcome you all again. And my name is Dr. Fatma Anouti. I'm from Zayed University, Associate Professor at the Natural and Health Sciences, specifically at the Public Health and Nutrition Department. And gives me great pleasure to be here with you today as a moderator for this great session, as I said. And I would like to also thank the organizers, Dr. Aisha Dahri and Dr. Layla Ismail, for this amazing effort, and everyone behind, or who goes behind the organization of this great successful conference. So our first speaker is Professor Senna Youssef Sha'ban, and Professor Senna is a university professor and a clinician and a researcher in the pediatric nutrition. She has, mashallah, more than 30 years of valuable experience in research contributions and teaching in the field of nutrition. She was awarded a couple of awards, including the Ain Shams prestigious award in 2008. And Professor Sana has founded the Nutrition Rehabilitation Unit and the Children's Hospital from 1997 until 2010. She was also the head. She also founded Clinical Nutrition Rehabilitation Unit, and she has supervised more than 300 students in the master's and the PhD program. She has more than 100 publications in the field of nutrition pediatrics. And Professor Sana is going to talk to us today about prebiotics, probiotics, and immune regulation in the early life. Very interesting topic. With all, we would like to welcome you, Professor Sana.
Thank you very, very much, Dr. Fatma, for your very nice and I'm really impressed your presentation for me. It's an honor and a pleasure to join your session, especially that I see Dr. Zakaria. He's a good friend of mine. Hello, Dr. Zakaria. And I see also Dr. Keys. Welcome. Well, I would like to start my talk today to thank my great and deep thanks to Dr. Aisha Dahri, and I congratulate her honestly for this very, very prestigious and this amazing event. Lots of effort, lots of job done, and it's a pleasure to be with her and to participate with her and with Dr. Layla. They are my dearest sisters and my very good friends. I wish them all the luck and all the best in this session, in this, Congress and the next one. So tonight I'll speak about the Biotics family, which is something new. We knew all about the prebiotics and probiotics, but the biotics family would be the masters of the future. So the intestinal ecosystem, which is the gut, where most of our bacteria live, and which is very important for our immune system, as well as for the behavior and the brain, because we have the gut-brain axis. So everything honestly lies in the gut. So you should be gentle when treating it. Well, in this gut lives thousands of microbiota, and they have a microbiome, which is a genetic coding for them. They have genes like our genes, their genes are even much more than ours. So they should be respected. And if you respect it, you will have a good immune system, as well as a very good brain and cognitive performance. And you will have no long-term any diseases or metabolic syndromes and so on. So there is an interplay always between the gut mucosa, the nutrients, and the gut microbiota. It's a triple interplay. It's a triple relationship, which is very important to take care of it and to deal with it. Doesn't want to move on. Okay, sorry. Well, this is the difference between the microbiome and microbiota, because many people, they got mixed up. The microbiome is simply the genome, while the microbiota are the residents. The small, if it features the small personnels, the small bacteria which live in your GIT. And as you see here, it is more than 3.3 million genes for the gut microbiota compared to the human genome, which is only 22.3. And this will tell you that this poses a question. Are we parasite for the microbiome, or they are a parasite, a whole organ in our body? There are certain remarkable episodes you pass by them, starting in utero. I think this has been dealt by many of our colleagues. And then the mode of birth, and then how you feed your infant. And then with special emphasis on the weaning. And then the childhood, how would you feed your child? All these phases are crucial. And they have a very serious impact on the microbiota in the GIT, on the colonizing microbiota, and they would shape the development of the host immune system. So it is very critical to take care of all these phases. Now, immunity begins, as it was said, prenatally, and it is definitely influenced by the mother's internal ecosystem, whether she's healthy or unhealthy. She passes her own experience and her own microbiota to her newcomer. And she passes not only antibodies, the antigen experience she had. So this sets a stage for a whole generation of a proper or a bad immune system. Now, before we start, there are certain terminologies we'd like you to have a very good idea about them. We have the prebiotics. The prebiotics, pre means before, bio is life. The biotics, it is the science of life. So the pre, what comes before life. And you all know that they are in the form of indigestible food ingredients, which are mainly certain carbs or fibers or the undigestible carbs. And they are also now, they are manufactured, and these, they play a very important role because they, in simple word, they are the food for the microbiota living in your GIT. If you feed them properly, you have good, healthy microbiota. If you feed them wrongly, you will have a very undesirable end up. So prebiotics, they do play a role in the cognition, immunity, and even in the GIT tolerance. And this is very important because they help to develop the epithelial cells of the GIT. and they nourish the epithelial cells of the GIT, and they give you a very strong barrier which is going to prevent the adhesion of the pathological bacteria to the GIT, so they are protector of your GIT. And this is mainly through two main big mechanisms. Through being the food for the probiotics, they are mainly fermented by the probiotic, the bacteria, the good bacteria and not the bad one. And now recently, we are all speaking about the postbiotics, which are the end result of this fermentation. And now postbiotics are merging on the surface. You speak about a new era of nutraceuticals or nutraceuticals. They are the end product of the fermentation of these prebiotics by the good probiotic, and they will give you amino acids, short-chain fatty acids, peptides, and lots of nutritive elements and non-nutritive elements which play a very crucial role on the immune system. Now, this is the intestinal human in short. You have the gut microbiota, which is the triangle on the left hand. Then you have the dietary carbs, which are mainly what we call them the prebiotics, or what we call the fibers, and they should be fermentable fiber. This is very important. And this is what mimics what is present in the mother's breast milk, which you are speaking now all about it, which are the HMOs, or the human milk oligosaccharides. And these are the natural oligosaccharides in the breast milk. So you see that God has given both of them, the prebiotic, the human milk oligosaccharides, and lots of bacteria in the human milk. And these together, they join to do what is known as the symbiotics for a certain target and to reach a proper target. And during this process, you have the production of short-chain fatty acids, which are mainly acetate, propionate, butyrate, and these, they play a very important role in the fueling the epithelial cells of the GIT to keep them healthy in the blood supply, as well as they keep a low pH, which is needed for the viability of the good microbiota. As well, they stimulate the production of mucus, and so they give you another barrier to keep your epithelial mucosal cells, to keep them healthy and protected. On the other hand, they play a very important role in the balance between the T regulatory cells and the Th2 cells. It keeps the balance between the Th1 and Th2, keeping the balance between these two types of T cells, which prevents you from going into the side of allergies or autoimmune diseases. So this is how it protects you from the allergies also, and it boosts your immune system. You have here what is known as what is the role of the prebiotic. The prebiotic, they have a role in the immunomodulation, and they increase the healthy gut microflora, they inhibit the pathogen, and they enhance the nutrient absorption. Thus, it protects from disorders such as cancer, inflammatory bowel disease, diarrhea, and GIT infection, constipation, because they also master the motility of your GIT, of your intestine, and they cure the hepatic encephalopathy. You know that the lactulose which we give to patients with hepatic encephalopathy is eventually a prebiotic. And they act also as active agents which are going to reduce the obesity, because these prebiotics, they through their action in the liver, and they stop the liver, certain liver enzymes to go to produce cholesterol, and accordingly when you have a low cholesterol, you do not go, you have a lipid reduction, and you don't go to high blood pressure or cardiovascular disease, and it protects you from obesity, plus the fact that it protects from osteoporosis. Very important point, that prebiotics help very much in the absorption of calcium and magnesium, and they help you to build a very strong bone mass. So there are many compounds on shelf in the Europe with for calcium with a prebiotic combined together. Now, there are numerous mechanisms which are responsible for the bacterial commensal in the gut. They signal the brain through it. And this is mainly these bacteria, which are the probiotic, they send signals to the brain when they are the good one through the activation of the vagus nerve and the production of immune mediators and certain microbial metabolites, and they give the signal to the brain. It's a bidirectional relationship between the gut and the brain. The gut gives a signal to the brain, and the brain gives a signal to the gut through many pathways: autonomic nervous system, enteric nervous system, which is the second brain present in your GIT, and also through the vagus nerve. And the microbiota gut-brain axis plays a crucial role in the neurotransmission, neurogenesis, and the dysregulation is going to alter this process. Now, Ida. Sorry. Now we come to the probiotics. Probiotics, they are mainly 99. You need the prebiotics and the probiotics so that they can function, they can live. They are like human beings, they need to eat something. So what affects the composition of these microbiome? The age, of course, the young age is better because this wanes as we go older. Heredity, what he took from the mother during pregnancy, during lactation, the skin-to-skin contact, and the breastfeeding, and the weaning method, and later on the diet, the environment. And the most important point in the environment to highlight is actually the nutrition. The nutrition is a big part of the environment so that it can impact a good health, and it has a good effect on the health. And if you misuse antibiotics, you are going to do a dysbiosis or disbalance in your GIT, giving a chance for the bad probiotic or microbacteria to go there and live. So if you want to see that what is happening now, what these probiotics are doing. The probiotics, which are the good bacteria present on your left side, they have a defensive role because they keep the barrier through the secretion of mucin, the GIT barrier proper, and they modulate the immune function of the GIT. They help in the tolerance through the modulation of the GIT immune system, and through they strengthen your immune system, and they reduce the inflammation and the allergic reaction. In the very early step,
2 minutes. 2 minutes, please. 2 minutes, please.
Okay. In the very early life, the maturation of the GIT is important. Digestion, absorption, gut, brain, and the satiety also is very important. Probiotics and prebiotics together are known as symbiotics. Now, these symbiotics, they strengthen each other, and as an end result, they give what is known as the metabiotics. The metabiotics, or what you call the postbiotics, are byproducts or waste products of the fermentation of the prebiotics by the good microbiota. And the postbiotics are the short-chain fatty acids, antimicrobial, enzymes, various nutrients, hydrogen peroxide, and many other products. And these postbiotics, we call them the ghost probiotic because they are the ghost of the viable probiotic, and they are not live, but they help. They are the products of the fermentation, and this helps to innovate the fermented formula. But this is natural, and it avoids any technical challenge of colonization efficacy. Why do postbiotics? On the GIT, they have an immunomodulatory, anti-inflammatory, antimicrobial effect. Behind the GIT, they have a hypocholesteremic effect, anti-hypertensive, anti-obesogenic, and anti-proliferative effect. Now, the dysbiotics, which is the last terminology you should know about, it is the critical imbalance between the good bacteria and the bad bacteria. If there is an imbalance, your body goes into GIT disease, mainly the Crohn's, ulcerative colitis, and inflammatory bowel disease, GIT cancer. And outside the GIT, you can have the obesity with all the metabolic syndromes or allergic disease, or it can affect the gut-brain axis and people with depression, schizophrenia, or infants and children with autism or attention deficit disorder. Now, this is the picture of on the left of the normal gut microbiota, how it keeps the homeostasis and there is no disbalance. On the right side, there is gut microbiota alteration, and as you can see, there is a dysbiosis or disbalance, and the pathological have taken the upper hand. We call these end products sometimes the psychobiotics, which are the as we said, the mediators and the neurogenic transmitters which pass from GIT. In your GIT, 80% of the serotonin is secreted. That's why we call it the second brain. And so the dopamine are mainly formed in your GIT and not in your brain. So that's why it can control the brain. If you are depressed, you took a piece of chocolate, then your mood goes high because of the excess dopamine which has been secreted. So the blood circulation to the brain. And if you have a problem and you are psychologically upset, the effect of the brain on your GIT, you can have colics, vomiting, diarrhea, and whatever. And this is known as the psychobiotics. And you should take very good care of your GIT and of the residents there. The bacteria, the good one, you should feed them properly, take care of them, and rear them up in a proper way to keep you healthy and safe. And thank you very much.
Thank you so much, Professor Senna, for this exquisite lecture. Pretty sure there are a lot of questions, and we will ask all the questions at the end of the session, inshallah. So thank you so much again. And I would like to welcome our second speaker. It gives me pleasure and honor to welcome Dr. Zakaria Al-Salam. He is a consultant neonatologist and the chairman of pediatrics and chief medical officer in Saudi German Hospital in the Kingdom of Saudi Arabia. Dr. Zakaria is going to talk to us about the common nutritional practices that need to be changed in the neonatal intensive care unit. Dr. Zakaria holds a pediatric board from the Arab, Jordanian, Saudi, and MRCPCH and fellowship in neonatal and perinatal medicine. And he also holds a Master of Pediatrics from the University of Alberta in Canada and an FRCPCH from the UK. He is also a peer reviewer and a member of the advisory board of several scientific journals, and he has special interest in evidence-based practice, training, education, quality, and recently health economics. Welcome, Dr. Zakaria, and we look forward to listening to your talk.
Thank you so much, Dr. Fatima, for this nice introduction. First, I would like to thank Dr. Aisha for inviting me. It has been a long since the last time I've been there. Due to the COVID, I came back to Saudi Arabia, so I am here in Dammam, not very far. I hope next time we will meet physically and we will continue our prestigious conference. And also I would like to thank the rest of the organizing committee for the nice welcome and also the making it easy for me to participate. As you know that I'm a neonatologist, so I will focus mainly on premature babies. My colleagues already focused on the healthy newborn, especially in regard to the breastfeeding. So I will try to relate to the the studies presented earlier and so on. What made me interested in this, actually, I noticed over the years that, and I work in many, in some hospitals, and I also attended many conferences, and I noticed that the practice, unfortunately, lag behind the evidence. And people continue to look for evidence, and but unfortunately, very few who are looking to implement them. And on the other hand, also they wanted the magic bullet or the silver bullet to treat everything. And when in fact the evidence is already available and it just needs to be implemented, there is no need for extra effort or for extra resources. The resources are already right there, but they are underutilized. The best example is probably the breastfeeding. So I will go through some of those examples that I still continue to see them. And I actually ask my friends through the WhatsApp groups or through telephone conversation, what do you think I should speak about, and what practices that you still continue to see them? However, I would love to see one of the students look into those findings objectively and study them and see if the after intervention or after education and making people aware that will change the practices and also will change the clinical outcome. So let me go through some of them in the coming slides. So now the goal of managing the nutritional aspect of premature baby is not only to make them survive, but also to let them survive without adverse neurodevelopmental outcome. These babies now, they survive, and they survive more than before. So if you look at the studies from the state or even here, they are very much similar now in the Gulf region. You notice that babies who are born less than 2,500 grams, that their survival is 90%. So that's very much similar to the GCC countries. However, they still have respiratory distress syndrome, and they have chronic lung diseases, and some of them, they have bleeding in the brain. What strikes me that still necrotizing enterocolitis, which is a complication related to nutrition, is still present, and it constitutes major part of it. And it not only that it affects their health, but also it can contribute to their survival. At the beginning, the first few days of life, the death is mainly related to respiratory illnesses. And if you look at the babies who survive beyond 2 weeks of life, you will start to notice that they die actually because of necrotizing enterocolitis, which is the pink one here, if you can see it on your screen. So it constitutes major part of or proportion of death after the age of 2 weeks of life. Also the survival, they have long stay in the hospitals. That's not only death, but also they stay longer in the hospitals. And so 25% of patients who survive, they can have long stay in the hospitals because of necrotizing enterocolitis. Those who survive and manage to go home, they still have a chance to have cerebral palsy more than patients who did not have necrotizing enterocolitis. Cerebral palsy, developmental delay, hearing impairment, and also psychomotor problems. So it is a very significant illness. The neonatal complication can increase the cost by 4 times, and that is estimated in one study to increase the cost once the patient gets necrotizing enterocolitis to $250,000 will be spent extra if the patient gets this disease. This is the direct and indirect cost. So preventing this illness will lead to a very cost-effective strategy. So what do we see in practice? Number one, that we give those patients inadequate nutrition. Sorry for the typo here. It's the inadequate nutrition is in the form of delaying feeding in the first day of life. Very few patients receive feeding, especially the breast milk. And this will lead to blunting the mucosal, the mucosa of the gastrointestinal system. You need the feeding to enhance the hormonal, the gastrointestinal hormones, which eventually will improve the growth of the intestine. So what is it? What do they get, those patients? Unfortunately, they are not giving expressed breast milk, and there is no fortification of the breast milk. And because the people are worried very much that nutrition will increase their problem, and will also fortification will increase their chance of getting necrotizing enterocolitis, when in fact it's not the case. There is another problem in the NICU. There is a lot of variation in the feeding orders. So there is a variation in patient care. There is no unified standard for feeding. There is confusion between staff and parents. And also there is confusion with the among the junior staff, because one consultant will start feeding, the other consultant will come to stop the feeding. The same thing at night, many times that the feeding will be stopped. The variation in care will lead to major confusion, and also will lead to waste in the resources. The other potential harms related to variation in care: the patient will be kept in PO for no good reasons. There will be prolonged use of TPN. There will be sepsis, and also central line infection and cholestasis and poor weight gain. And that also will lead to delay in the discharge process of patients. So that's why we need to have feeding protocol in each unit. This feeding protocol should emphasize on the type of milk that we will give. It's not important to focus only on the breast milk, but also to focus on the formula, because sometimes the formula will be given to patients that are not suitable for premature babies. In some practices, I noticed that they are given term formulas because they are worried about the osmolarity and necrotizing enterocolitis. The advancement in fortification should be addressed in this feeding protocol. There should be criteria for stopping and restarting the feeding. There should be identification how to handle the feeding intolerance, because there is a lot of confusion about what is feeding intolerance. Little bit of milk in the stomach. What about the color? What about the amount? If there is symptoms or not? Usually these are not handled, which leave the staff at night very confused about the feeding. And also the feeding protocol should focus on when to start the feeding as well as when to stop it, and when to focus also on the trophic feeding. Trophic feeding, for those who are not familiar with the premature neonate, it means the amount of feeding that will enhance the trophy, which is the growth of the intestine. So the feeding protocol should be very simple, inexpensive, and should be effective and transmissible to the rest of the staff. Should not be complicated, so people will carry on during the weekends and during the nights how to feed those patients. Is there evidence that feeding a protocol will improve the situation? Yes, there are actually evidences, and this is one of the studies. I'm giving you only one example here. This study, the authors and the colleagues, they they promoted the breast milk feeding, and they initiated the feeding within the first 24 hours. They also added fortification. They did not forget the phosphorus and vitamin D, which was addressed by earlier presentation. And also protein, they can lose up to 1% of their total body protein every day. And that's a major loss that you need at least 2 weeks to get it back. The same thing with fat. fat, and in some hospitals started, or in some practices started at very little, or even not started because of worry about jaundice or pulmonary hypertension and so on. But our recommendation is to start at least 2 grams per kg per day and build it up to all the way to 3.5, and even you can reach 4. And I know the recommendation of some depends on the type of fat, but if you're looking at SMOF, that is something different. Breast milk, unfortunately, in so many hospitals is not being promoted, and if that is the case, you will notice that necrotizing enterocolitis, sepsis, and bonding and cost will increase in your hospitals. And providing breast milk has been shown by so many evidence that it decreases the necrotizing enterocolitis plus late onset sepsis and death. We created breastfeeding support group committee, and this is the term of reference. And also we had so many policies to help us with that. We gave the mothers a guide to the breastfeeding. When I moved also to the UAE in Al Ain, we started the BFHI course, and that is readily available also on the internet, but you need to have an educator. All the GCC countries now, they have royal decree or an order from Majlis al-Wazara or the Prime Minister. You will find it in every hospital, and this is a royal decree from the Saudi Arabia. We should not forget the formula-fed baby, because some mothers, they will not be able to feed because of some other reasons. So we need to have a very well-informed consent for those mothers. And this is another consent for supplementing a newborn with the breast milk. So what did we find when we started the protocol, and we will put all those evidence all together, that the exclusive breast milk in small babies, I'm talking here about babies less than 1500 grams, increased from 0% to all the way to 90% and later on. Those babies are small. They were 28 weeks and their weight is 1000 grams. And their rate of necrotizing enterocolitis has reduced from 15% to 3.4%. And also the severe necrotizing enterocolitis reduced from 8% to 2.8%. And that is reflected also on sepsis, coagulation negative staph, gram-negative sepsis. Candida became so rare, like in 2 years, in 2 years, we get only one candida infection in a hospital that is very busy. That is reflected also on the other comorbidities, like the use of other medications that indicates the severities and so on. The survival reached almost 90% of those babies. So what I'm trying to say here is that when you try your best to implement the best evidence and supported by the quality improvement project principles like BDCA cycle or Six Sigma or anything, that tools to improve your processes, and try to implement the best practices through a team that is enthusiastic to implement that. What will happen? You will get the best results. So when we did that, we found out the following: implementing evidence-based practice through the quality improvement project was associated with lower rate of necrotizing enterocolitis and sepsis and other comorbidities. There is a need for further implementation. This is what I want the students to have, if there are students. There is a need for further implementation of evidence to sustain improvement and decrease the other comorbidities. These are the references, and thank you so much for listening.
Thank you. Thank you so much, Dr. Zakaria. And please stay with us for these questions at the end of the session. Thank you again. And now I would like to welcome our third presenter and speaker, Dr. Mahmoud El-Halik. He's going to speak to us about vitamin D deficiency in neonates. And Dr. Mahmoud, is he available?
Yes. Good evening.
Yes, so Dr. Mahmoud, welcome. I just want to briefly introduce you. So Dr. Mahmoud is the consultant neonatologist and head of neonatal ICU at Latifa Women and Children Hospital in Dubai Health Authority, UAE. He is the director of a neonatology fellowship program at DHA, and is also a neonatal resuscitation program instructor and mentor. He has more than 25 years of valuable experience in perinatal neonatal medicine, and he has a special interest in neonatal nutrition, neonatal sepsis, quality improvement projects in neonatal ICU and resuscitation. He is chairing and co-chairing in different hospital committees, such as the Neonatal ICU Infection Control Task Force and Antibiotics Stewardship Committee. And he has several publications. I would like to welcome Dr. Mahmoud to give his talk. Welcome.
Thank you, Dr. Fatma, for the nice introduction. And I would like to thank Professor Aisha for inviting me for this eminent scientific event. I'll just share the slide. You can see my slide.
Yes.
Okay. My topic is about vitamin D deficiency in neonate. These are some of the references used. And I'm going to run quickly through the topic of vitamin D deficiency with some stress on certain points. Yesterday, while I was preparing, or on the 12th of March, when I started preparing the presentation, vitamin D has been studied in all continents, in most of the countries, and on the PubMed, there was almost 5,500 epidemiological studies with more than 24,000 articles. And all these studies reveal that vitamin D deficiency across all the age groups, geographic regions, and seasons is prevalent, vitamin D deficiency. Now, being a consultant neonatologist, one of the major tasks is to protect the premature babies, knowing that every year we have almost 15 million babies are born preterm, more than 1.1 million die. So definitely there should be a proper management for these premature babies in order to increase the survival rate without any comorbidities and without, to have a nice child going home. For instance, we have down to 450 grams babies discharged from our hospital, in Latifa Hospital, because we have established a system having proper guidelines for everything, not leaving any chance for missing anything related to these babies. Now, vitamin D deficiency could be an under-recognized global problem because there is increasing reports of rickets and vitamin deficiency worldwide. And as you have seen in PubMed, more than 25,000 articles. Vitamin D deficiency has significant morbidity and mortality, and it can be simply prevented by proper vitamin B supplementation, especially in the pregnancy stage for the mother and for the babies, and especially for the preterm babies. Vitamin D is a fat-soluble vitamin. It plays an important role in calcium homeostasis and also many other health issues. It is considered like a hormone with pleiotropic effects because it is already known by now that receptors for the vitamin D is present on almost every cell in the body. The active form of the vitamin D is vitamin D3, the cholecalciferol, and vitamin D2, almost 30% activity of the vitamin D2. Now, a global summary of the maternal and newborn vitamin D deficiency status, a systemic review. It is prevalent in pregnant women, newborns, and all over the world, and covering all the regions of the WHO. In a recent study, I will show the figures now. So this article was published in 2016. Vitamin D deficiency is present in pregnant women, newborns, and should be, I don't know how to remove this. So this is the prevalence of the vitamin D. You can see covering all the regions of the world, and there is a huge alarming figures like 96%, 87%. Globally, we have up to 75% in the newborn. So this is really alarming. The prevalence I'm trying to remove the screen because it's covering the slides, sorry. The risk factors associated with low maternal and neonatal 25-hydroxy-vitamin D concentrations in the Middle East specifically, we can see that there is decreased vitamin D synthesis due to reduced exposure to sunlight and the decreased dietary sources, which can be attributed to dietary habits and vitamin D replacement, along with personal factors, the dress, the living in closed places, the air pollution, and of course, the newborns. It's directly linked to the maternal and cord blood vitamin levels. In this study published in 2019, it was found that almost 75% of the Middle Eastern pregnant women and their newborns are either vitamin D deficient or insufficient. And of course, dietary intake alone is not sufficient. And they advised at least 4,000 units of vitamin D for the pregnant ladies. Earlier study from Saudi Arabia in 2016 also showed an extremely high prevalence of maternal and neonatal vitamin D deficiency in the Arab population. Now, how the vitamin D, or what's the role? It increases the calcium and phosphorus absorption, enhances bone mineral density, increases insulin. It works on most of the parts of the body. And the fetus is completely dependent upon the maternal supply of vitamin D, and 25-hydroxy vitamin D crosses the placenta, but this, if the mother is deficient, the infant will be as well deficient. Looking at the vitamin D, of course, from the either generated in from the skin or from the food until it reached the liver, the effect of vitamin D, as I mentioned, it works on multiple systems in the body. In children, when the vitamin D level is good in the starting from the mother, there will be less risk of SGA, less risk of rickets or neonatal hypocalcemia. In the pregnancy, less risk of preeclampsia or bone loss. It boosts the immune system and it increases the bone density. So all these things shows the importance of vitamin D. To add to this, a low vitamin D status, when we add to the extra environmental factors, the epigenetic modifications due to other factors, which can affect the human being or the human fetus, it becomes a very important part, because adverse health outcomes across lifespan can happen if there is a vitamin D deficiency along with other factors. So as I mentioned from the beginning, these tiny babies we want to support in every way so that they can live a normal life. So when there is deficiency, it can affect the pregnancy, leading to preeclampsia, preterm birth, gestational diabetes. The infant, he can go into preterm birth, allergies, respiratory infection, rickets, hypocalcemia, and the child later on goes into wheezing and food allergies and autism. The level of vitamin D, agreed one or the most common one used, is the one from the endocrinology, and these are the levels: the deficiency less than 20, toxicity more than 150. In a recent article, but of course until now, there is no specific range for the neonates, and the preferred one is 30 to 60. In a recent article in 2018, they defined the deficiency, insufficiency, and sufficiency for vitamin D, and by different institutes which look at this thing. And as you can see the figures in front of you, there is no agreement even on this, what is the deficiency and what's insufficiency. And even this area, there was no consensus on it. And this is like most of the problems which we have in the medicine, that there is no consensus on one thing to be followed and done. The means of giving vitamin D for the newborn, and especially for those who are admitted to the NICU, it can start either with parenteral nutrition, and he can get vitamin intake from 160 to 400 based on the parenteral nutrition and the multivitamin which he take. Of course, there is guidelines which tell from day one what the baby will take. Like we start with 2.5 grams protein, we start with lipid and the multivitamins. Everything is put like this. You can guarantee that you are giving the proper care for the baby. So if he's parenteral nutrition, this is what he take. If the preterm, he takes up to 400 international units per day. The full term, this amount. Special cases like cholestasis, and there is difficulty in absorption of vitamin. Their vitamin drops and vitamin D will be much higher than the usual. The means of giving vitamin D, it's good to know what the babies take. So either a human milk or mother on usual intake, it will be less than 100 international units. If fortified human milk in preterm infant, the amount can be 280 to 380, approaching the normal level to be given, and depends also on the age of the baby, and preterm formula in this range. Also, the regulatory guidance and common vitamin D content of routine cow milk-based infant formulas, if it is used, because, for instance, in our unit, we reached almost 85% breastfeeding and fortification for our babies. So if you look at the most of the formulas from different regulatory systems, USA, Europe, USA formula, the amount is the minimum amount when he take 1,000 ml daily formula, it will be in the range from 260 to 670. So he can be time deficient if this is not attended. So if we want to look at the baby adequate intake, if we take the proper intake, a breast milk plus drops or formula containing 300 to 500, maternal supplementation 6,400 international units per day, then the mechanism of action of vitamin D on his body will be running properly, and his minerals and the calcium will be okay, and his bones will be normal, along with many other things we will see. Of course, if there is disturbance, all the mechanisms related to absorption of calcium or mineralization of the bone will be affected, and the baby will be affected. I'm not going to go through this, but there is a balance between the phosphate, the calcium, and the vitamin D. So vitamin D production stimulated by high parathyroid hormone and low phosphate. And that's why when we investigate any baby, we look at all these parameters to know what he's having. We check the vitamin D level, we look at the plasma calcium, the phosphate, the alkaline phosphatase, the parathyroid hormone, the 25-hydroxy, and along with the X-ray, and based on this, the management of the baby will be done. Now, signs of vitamin D deficiency in the newborns in general, some might be asymptomatic. One common thing is the craniotape. Other osseous signs such as osteopenia or prematurity are seen, especially in the preterm babies, hypocalcemic seizures, and the hypocalcemia. The craniotape, one of the earliest signs, if you press on the skull, you will feel like a bing bong. It will go in and out due to thinning of the outer table of the occipital or parietal bone. If we look at the stages of vitamin D deficiency, whether it is severe or insufficiency or adequacy, and what's the effect on the mother and on the newborn. In the newborn infant, if it is severe deficiency, there will be, he will be from the beginning small for gestational age. He can go into neonatal hypocalcemia, seizures, heart failure, enamel defect, rickets, and of course he can be, if it is, within the adequacy, there will be no symptoms unless he's exclusively breastfed and he's not getting vitamin D drops, because the vitamin D is much less in the breast milk. In the preterm babies, of course, these preterm babies, when he's born 500 grams at 24 weeks, for instance, these are especially vulnerable because loss of the third trimester mineral accretion, increased needs, and relative immobility. As I mentioned, the milk breast milk is inadequate with vitamin D. So these preterm babies, they are at greater risk of vitamin D deficiency, and almost 10 to 20% of extremely low birth weight infants have radiological evidence of rickets. One of the major problems is the metabolic bone disease of prematurity, and one of the major cause of it for this premature is the vitamin D deficiency, which can end with a fractured bone or many other symptoms. Now, one of the signs which was recently or in the last few years noticed, previously the tremors, even the tremors which happen with the baby, it was found to be due to vitamin D deficiency. So always one of the earliest signs which can be noticed in a baby, if he's having continuous tremors, it can indicate that there is vitamin D deficiency. Other signs which can happen, this is a case which presented to the emergency at the age of 10 hours. Usually when we say there is severe hypocalcemia of the baby due to vitamin D deficiency, it appears after 2 days. This one appeared after 10 hours, which means there was severe vitamin D deficiency both in the mother and in the baby. And of course, with the correction, the baby became okay. Another case which presented in state in one of the American hospitals, a baby came with in a cardiogenic shock, and it was found after full investigation it is due to only severe vitamin D deficiency. And when it was investigated, it led to dilated cardiomyopathy with decreased ejection fraction of the heart. So the whole function of the heart was affected because of the severe vitamin deficiency. And of course, there was signs of nutritional rickets. And with the management and with the treatment, the baby became okay, and the ejection fraction went up to 43 after it was 20%. Now, one
Dr.
study.
Mahmoud, we have a few minutes, 2 minutes, please.
Okay. Vitamin D checked in Turkey, they found that 56% of the babies lack vitamin D, and this is associated with hypocalcemia. And the problem of vitamin D, in one nice article, it was saying that it is like an iceberg, because recently in Europe, they found that because of the influx of the immigrants, the cases of vitamin D deficiency is becoming more. Like we have, this is a cardiomegaly and signs of rickets. And they emphasize that there should be more health awareness and work on the public. This is an example of a premature baby with a fracture, with periosteal reaction, signs of rickets, metaphyseal widening. And when he was put on the proper diet and vitamin D, there was correction and there was no other signs. Congenital vitamin D deficiency is extremely rare, and newborns can have symptomatic hypocalcemia, IUGR, and decreased bone ossification. And recently, or not recently, in 1974, the first case of congenital vitamin deficiency was published. But until now, unfortunately, it is going on, because in this article, they are saying congenital rickets cases seen simulate a tip of an iceberg, and its prevention is an important issue. And if you can see, all these publications are cases of congenital vitamin rickets, which indicate that we are in a serious problem with the vitamin D. These are also examples of the fracture, of the rickets, of the rosary, the complete picture. Some investigation was done to see if there is link between severe vitamin D deficiency and respiratory distress syndrome. One of the problems which happened with a premature baby, there was clear risk factor for RDS in the premature infants with 25-hydroxy vitamin D deficiency. Another study looked at the bronchopulmonary dysplasia, and they found that there is antenatal vitamin deficiency and low vitamin D levels are associated with neonatal bronchopulmonary dysplasia. Another study done to see if there is, or systemic review and meta-analysis, if there is a relation between vitamin D and neonatal sepsis, and also low levels of vitamin D, both in pregnant mothers and in the cord blood of the newborns, were significantly associated with neonatal sepsis, and especially the early onset sepsis. Morbidity also showed that high prevalence when there is vitamin D deficiency of RDS, respiratory syncytial virus bronchiolitis infection in the preterm babies was found to be much higher when there is vitamin D deficiency. And a study was done for the mothers to
Dr.
see.
Mahmoud,
Yes,
can you please wrap up, please?
2 minutes, I'm finishing. Given 6,400 units compared to 400 or 2,400, the p-value was excellent and showed that the vitamin D deficiency was much less in these babies. long-term effect, they looked at this study at those who were born with vitamin D deficiency in this period, 901 mothers, and they found that the lung, there is effect, it impaired lung volume, the brain, there is neurocognitive difficulties, and the bone positive lower beak bone mass. Of course, we give for the babies 400 international units. There is no consensus for the preterm. All these institutes, they give different values. So the giveaway message, unfortunately, it is still reported with so many morbidities. It can be prevented by giving proper vitamin D for the mother and for the babies. And always there should be awareness about this topic. Thank you very much.
Thank you so much, Dr. Mahmoud, for this interesting topic. And I'm pretty sure there are a lot of questions at the end of the session. So I would like to move to our last speaker, Professor Kees de Graaf. And he is a professor of sensory science and eating behaviors, and also the chairman of Division of Human Nutrition at Wageningen University. I hope I pronounced it correct, and apologies if I didn't, in the Netherlands. Professor Kees is a nutritionist who earned his PhD in 1988 in an interesting field of taste psychophysics. He has published more than 300 scientific papers, mainly on the psychobiology of eating behavior, and he has an H index of 61 and also has been cited more than 12,000 times. His research and teaching activities revolve around the meaning of sensory signals, such as taste, odor, texture for eating behavior and regulation of energy intake. And a significant part of his career is focused on understanding of development of food preferences in infants and children. He's a section editor of the Journal of Physiology and Behavior and associate editor of the Journal of Food Quality and Preferences. Please welcome me all. Join me in welcoming Professor Kees.
Thank you very much. Can you hear me properly?
Yes.
Okay. Yeah. First, I would like to.
Can you share the slides, please?
Yeah.
Share your presentation.
Yeah. I will share the screen.
Thank you.
Where is my presentation? Can you see it now?
Yes.
Okay.
Great.
Okay.
If you can just put it on full screen, please.
Yeah.
Thank you.
Well, first I would like to thank Dr. Aisha and also Dr. Laila for this invitation. To be honest, I would have preferred to be in Dubai now. Yeah, I think it's warm and pleasant now in Dubai, whereas in the Netherlands, where I'm at my home in the attic, and this weekend it will start freezing again, so it's cold and rainy here. So yeah, I hope next time it's in Dubai and that it's warm and sunny. But for you, it's already getting late, of course. So what I would like to talk about is the development of food preferences in babies and toddlers, so until the age of about 3 years. And I would like to discuss the case of vegetables. Vegetables, I worked on this area for, I think, more than 20 years. I still didn't solve this issue, but it's exciting and it's interesting, but it's also difficult. And I guess that will also apply to Arab nations. I hope that after my talk, you understand that there are universal preferences for basic tastes like sweetness, fatness, savoriness, but most preference for foods and flavors are learned. There are a few mechanisms by which you can learn to like certain foods. That's main one is exposure, repeated exposure. A second one is flavor nutrient learning. So if you associate a flavor with a particular nutrient, I will come back to that later. Flavor learning. So if you pair it with sweetness, that may help. Modeling is of course important, and social learning is also important. Another aspect about vegetables is that vegetables are a very particular group of foods compared to other foods. They have a very low energy content. They have, of course, they contain micronutrients, but low macronutrients, and they also have very low basic taste intensities. Actually, I don't think they have much taste, and therefore they're not liked. And finally, I hope that after my talk, you will recall some of the studies and the evidence on the development of vegetables. Of course, vegetables are healthy. They're protective for various nutrition-related chronic diseases, like vitamin A, of course, micronutrient deficiencies, but also in relation to, I would say, cardiovascular diseases and obesity. People who eat a lot of vegetables, they have a lower risk of cardiovascular diseases, cancer, and also obesity. In most countries in the world, vegetable intake is too low, particularly in young children, and I think that's also the case in Arab nations. And I guess the combination of vegetables in Arab countries is not so optimal because of vegetables is mainly water. And you can ask yourself, why do young children have such a low vegetable intake? I will discuss that first. Discuss the development of food preferences, some general principles, then show to you that vegetables is a special group of foods, and then I'll share with you some work that we done on the development of food preferences of vegetables in babies and toddlers, and finally a short discussion. To start with, I think it's very clear that we have an inborn preference for sweetness. Babies just after birth, they enjoy sweetness, and that continues to be the case across the whole life. People across the world, they also have a preference for savory foods. Also in Dubai, where I ate several savory foods, and people also have a preference for fatty foods. People have an innate aversion for bitter, that's related to toxic substances, and sour, that's related to unripe fruit, and people do not like high intensities of bitter and sour. They do like low intensities of bitter and sour, like you have, for instance, in alcoholic beverages like beer or wine. I think the preference for salt is develops in the first year of life, and is also universal across the world. Everywhere people like salt, and I think the preference is very difficult to change. So I think taste preferences are stable, but to some extent modifiable. Food is much more than taste alone. It also includes smell, texture, appearance. And I think most food preferences have been learned through experience. And I guess that's the reason why Dutch children like cheese and Indian children like curries. And yeah, that's of course very different across various countries in the world, but taste intensities across the world, they are more or less similar. If I go to Dubai, I perceive similar sweetness and savoriness and fattiness compared to the Netherlands. When you look at the development of food preferences, the first year of life is critical. It's very open, babies are open to new flavors, so you can learn to like them anything. At about 1.5 to 2 years of age, people start with, children have neophobia, so they are declining to learn to like new foods. Before that age, they can learn anything. So I think it's important to define the learning mechanisms when introducing complementary foods. And what you see at 2 or 3 years of age, that specific preferences are established. And these preferences, they continue to hold on until adulthood. And some of them are very, very stable. So for instance, I have a preference for old Dutch cheese, and when I was 3 years old, I had the preference, and when I die, I still have that preference. So that's very stable. How can you learn to like some foods? I think the main mechanism is repeated exposure. So if you expose someone repeatedly to a certain food, they will gradually learn to like it. And I think that's related to what you would call learned safety. You learn that broccoli is safe to consume and that you don't get sick of it. The second mechanism is what you would call flavor nutrient conditioning. That's related to a feeling of satiety. So if you pair a certain food with energy, be it carbohydrates or fats, then you learn to like it because you get satiated after eating it, and being satiated is a pleasant feeling. Flavor learning is that you associate a certain flavor with, for example, the sweet taste. So if you pair, say, the flavor of a vegetable or something else with a sweet taste, this is an example in the Netherlands. Maybe I should have changed it, but this is apple compote, which has a distinct sweet taste. So if you mix that with vegetables, then and maybe through the association of vegetable taste with the sweetness, people learn to like it. And after that, of course, role models, social reward and punishment, these are also important mechanisms for learning to like or learning to dislike certain foods. The effect of exposure already occurs very early in life. One very, I think, exciting and prominent example is a study of Julie Manella, published about 20 years ago, where she gave pregnant mothers, she gave them in the last trimester of pregnancy, she gave them either carrot juice to drink or water. A second group was that during lactation, the mothers consumed carrot juice or water, and in the control group, both groups only consumed water for a couple of times per week. And the dependent variable in this case was a preference test at weaning, where children compared a carrot flavored cereal compared to a plain flavored cereal. And what is exciting, I think, is to see that what you see is that those babies whose mother had carrot juice to drink during pregnancy or during lactation, they have a higher intake of the carrot flavored cereal compared to the mothers who only drank water. And also when you look at the negative facial expressions of these children, which you can monitor with face readings, and you see that these are much lower in the children whose mother drank carrot juice. So the effect of exposure is already present in utero and before birth. And I think it's a very powerful mechanism. Vegetables. That's I would like to discuss with you that this is a special group. We did a lot of taste work on vegetables, and yeah, of course, vegetables, they have a low energy density. That's also the reason why you don't get fat from vegetables. You can eat a kilo of spinach and yeah, then you still have a low calorie intake. But vegetables also contain a small amount of macronutrients. They don't contain any carbohydrates, no fat, and no protein. And they also have a low intensity of basic tastes. About the taste, we measured taste intensities of a lot of foods across the Dutch food supply, but that will also apply across other food supplies. So we looked at the taste of spinach, of apples, of chocolate, cheese, mayonnaise, and coffee. And what you actually can see is that spinach, it's not sweet, it's not umami, it's not fat, it's not sour, it's not bitter, and it's not salt. Whereas all the other foods, they have a certain taste, and like cheese is umami and fatty, mayonnaise is of course only fatty, coffee is bitter, and apple is a mixture of sweet and sour. But spinach, just like cauliflower or broccoli, it just doesn't have a taste. And the reason is that it also doesn't contain any macronutrients, and the spinach doesn't contain any carbohydrates, no protein, no fat, and no salt. So I think this is the basic reasons that vegetables are not liked. And if people consume vegetables, they mainly consume it in combination with salt or fat mainly. And in many cases, people add salt or fat or umami taste to the vegetable to make it palatable. And I think that's also applies for UAE. One question that you can have is, are the first years of life a kind of window of opportunity to learn to like vegetables? About 20 years ago, I started on this area, and we started to investigate vegetable preferences in young children, in children who go to school, so like of 6 to 12 years of age. That didn't work very well, so then we started to look at an earlier age, and at some time we came upon the age between 1 and 3, which is the toddler age. And I will show you the results of 2 studies, one with flavor nutrient learning and one study with flavor learning. And these studies were carried out with 1 to 2 year old children in a nursery, in a kindergarten. And these are the 2 principal mechanisms. I will explain them a little bit further. What we did, we first measure the preferences of the foods. Then we have an intervention for 7 weeks. And then we do post-tests where we also measure the preference. And so in this case with the soups, children are exposed to various soups, then they get exposed. And after the conditioning, they get a preference test again. And we do that, the preference just after exposure and also after 2 months and after 6 months. This is the first study on flavor nutrient learning. What we do, we made endive soup and spinach soup. Not sure whether you will like it, but to one of them we added maltodextrin, which is a tasteless carbohydrate. So it doesn't taste, but it does add energy to the soup. And then the assumption is that if you add energy to the soup, which is low in calories, that the children get satiated and feel comfortably full afterwards, so that they learn to like the flavor of endive or spinach. We did that with 40 toddlers with a mean age of about 36 months. The second study was on what you would call flavor learning. We had beetroot chips and parsnip crisps. And we asked the children to dip it with a certain flavor, either with a white sauce or with tomato ketchup, which is of course sweet. And the hypothesis was that if you dip it with the tomato ketchup, then you learn to associate the parsnip or the beetroot with the sweetness of the vegetable, and then eventually you learn to like it. Let us see the outcomes. This is the soup study. And what you see is that pre-test, this is the soup intake with the children. This is the intake at the post-test. What you see is that the exposure of 8 times to the soups, either being the low-calorie or the high-calorie soup, results in an increased intake, but you don't see a difference between the 2 conditions and between the high energy and the low energy. So exposure works, but flavor nutrient condition does not work very well in this case. This is the chips study. This is the intakes of the vegetable crisps. And here we see a little bit the same, that exposure seems to work very well. Children learn to like the crisps of the parsnip and the beetroot. But the increase in liking or consumption is more or less similar for the unconditioned compared to the conditioning stage where they consumed it with the tomato ketchup. So yeah, the conclusions of these studies, and I think the many other studies in this field, is that you see an increase in consumption of crisp and in vegetables in all conditions. So repeated exposure works, and the effect on intake remains stable over time, so also after 6 months, but there's little added value in the flavor nutrient or flavor conditioning. So we know a little bit how it works, but not entirely. So yeah, I think vegetables stand out because they have a low energy density, a low macronutrient content, and also low basic taste intensities. Repeated exposure works when introducing new flavors, new vegetables, but we are still not able to increase the vegetable intake substantially. And I think for older children, additional strategies are needed. To me, this has been an exciting field to work in, but I must confess that after 15 years of work on vegetables and children, I still don't know how to increase vegetable intake in children, except for mixing it with sweet items or fatty items or salty items. And then if I eat Brussels sprouts in a cheese sauce, then I really like it, and most people can have a good amount of vegetables. And similar with a salad, if you mix it with tomatoes and cheese and onions and a mayonnaise sauce, then it's easy to consume. But pure as such, it's much more difficult. So this is still an exciting area to work in, and I think it would be very exciting to also look at the vegetable intake of children in UAE and see whether we can learn Arab children to learn to like vegetables and to increase their intake. These are some papers on which this work is based, and I thank you for your attention. And I give back the floor to the chair. So.
Thank you so much, Professor Keys. And I can open the floor now for the questions, actually, because we're running out of time. So we was restricted to only one question for each of the speakers.
Yeah.
I had plenty of questions, but I had to filter them. And, you know, I really want to thank each one of you for an amazing session. I think, you know, it's very true indeed. Keep the best to the last. Like, you know, this is really an awesome session, and I'm very honored and privileged to be the moderator for that session. We had a lot of interesting talks, as we said. Started with like the prebiotics, probiotics, then about the best practices using evidence-based approaches for neonates, leading to deficiencies, particularly vitamin D deficiency in the neonates and its impact on the neonatal health, to lastly about how to try to modulate the preferences, food preferences for infants. And it's really very interesting. So I would like to select some of the questions that we received. And the first question is for Professor Senna. And it was a question about, do you recommend consuming organic foods that are highly enriched in probiotics? And I think they meant here probably prebiotics.
Yes,
exactly.
Because they have to differentiate. The prebiotics are carbs.
Exactly.
Present in plants and so on.
Right.
But the probiotics are the bacteria, either they are living inside you or they are in fermented foods, such as the yogurt, the sauerkraut, and so on.
So I think the question was like, maybe there's a misconception that organic foods are really enriched in prebiotics.
No, they are not. They are not. A plant is a plant. Whatever you add to it, it doesn't change. And I would like to as one of the speakers, to have at the end one question to Dr. Keys. One question.
Sure. Go ahead, you can ask it.
Okay, I think, Dr. Kiss, the problem is with the behavior, yes, for this problem of vegetables. Because as my time when I was a little girl, we used to have the food, family food on table. Everybody eats everything. It was not a problem. Now I recognize that the problem is with the very fast life, with the working mothers. They do not cook. They do not teach their children what to eat. And everything is ready. No vegetables are ready. So what's your opinion?
I think that's partially an explanation, of course, that hey, you don't have family time to share with the children. I do think it remains an issue that vegetable, even with families on the across the table, I think you need to pair vegetables with other flavors to get a higher intake. And of course, it's highly recommendable to share foods with others and not to eat it alone or on the street and with a fast rate. So food is there for us to give pleasure and to entertain the family and to communicate and talk about things. And I think that's what food should be.
Yes, you are quite right. So do you have picky eaters?
Yes.
What do you do with them? It's a hell of...
Well, I think it's slowly with vegetable intake increases across lifetime. You see that so elderly people, they consume much more vegetables than children. So I think slowly the problem resolves. But yeah.
We hope so.
Yeah, but it's
yes, but mom comes the way that if you have the magic stick, you will make them eat the food tomorrow, the vegetables tomorrow.
Yeah.
Thank you, Professor Keith.
Thank you.
There's a question for Dr. Zakaria, and it's how do you educate about feeding intolerance, and also what do you do if the expressed breast milk isn't available at the hospital?
Well, here my focus is only mainly in premature babies. So feeding intolerance here we mean by mainly it's in the form of regurgitation or a little bit of spitting or a little bit of vomiting. The color of the milk could be a little bit greenish or sometimes just mucus or just clear fluid. And sometimes it is a little bit of blood. So it depends on the type of the vomiting, the amount, and the residual in the stomach. We will be able to signify the feeding intolerance. With that, we need to do the physical examination and see if the abdomen is distended, if it is discolored, if the patient, if the baby passed stool or not. So, and we look also at other symptoms like apneas, which is stop of breathing, cessation of breathing, or there is a little bit of oxygen, or if there is any other sign and symptoms that the baby might have. We have to put all this together with them, and then we have to reach a conclusion. But most of the time, actually, it is just a little bit of abdominal distension, little bit of vomiting, which is not significant. And usually doctors, they stop feeding for unnecessary reason like this. So it's better to have a protocol for this, where the staff will agree this amount of vomiting, this amount of feeding intolerance, we will ignore. This amount we will watch. This amount we will have to stop feeding. So if we have a consensus about it, we'll be able to have a systematic approach that is consistent with a little bit of variation. And the other question you said about?
I guess it was expressed if they don't use.
Well, in this case, the only thing available is in our country or in our region is preterm formula. We don't recommend to use term formula for premature baby or hydrolyzed formula because I saw that question. Well, and also there are some mothers or some cultures, some tribes, they still continue to have donor breast milk from the sister or from the neighbor and so on. But this has to be taken into consideration where the status of the mother health should be known, like the HIV, the hepatitis, and so on should be known. And usually those mothers actually, they have gone through the antenatal screen and postnatal screen, and they are usually healthy. There should be a policy for that to address it, because it's a cultural thing. And I think I personally should, I promote this kind of practices under certain guidance. Donor breast milk or from manufacturer companies is not available in this part of the world. The religion has a big say in it, and we need to ask the clergy before we start implementing such practices.
Thank you, Dr. Zakaria. There's a question for Dr. Mahmoud. There were a lot of questions, but I tried to filter the ones that reflected some kind of a misconception, maybe. There was a question that asked whether, like, if the mother is taking supplements, is this fine? You know, do they have to also give supplements to the baby if the mother is breastfeeding the baby? They think that they don't need to supplement the baby. So.
Yes, actually, you can hear me?
Yes.
Yeah, actually, yes, they have to give the baby, because the last few slides which I was going through, there was some studies which showed clearly that many times the amount which is given to the mother even is not sufficient for her to be vitamin D adequacy. So even if she's taking supplements, she has to give the baby. One study they did, they gave 6,400 international units for the mother on daily basis. With this, the amount of vitamin D in the mother was adequate, and there was no vitamin D deficiency in the babies. But when they were using the 400 and 2,000 plus, there was vitamin D deficiency in their siblings. So that's why it's better. It is a must that they should give their babies.
Mm-hmm. All right. Thank you so much. Professor Keys, there's also one more question. They're asking whether mother-led weaning would be helpful in terms of food preferences for the baby or the infant.
Yeah, well, I think what you do at weaning is, of course, incredibly important for food preferences. If you do that in a proper way, in a positive way, stimulating babies to eat different foods, different flavors, as well, Professor Sana said, in a kind, communicative way. I must say, I also, as a parent, my children didn't always eat vegetables, and then I get a bit grumpy. Mm-hmm. And I say, "Oh, eat your vegetables." I think that's the wrong way. Mm-hmm. You shouldn't do that. So you should stay positive, non-coercive. So not trying to force children to eat, but offer it again and again and again, and say, "Oh, wow, here's a nice vegetable." Yeah, so it should be. I think it's important that eating is pleasant, and yeah, and that's the way you raise good habits. Yeah, and not too strict or too grumpy or angry. I don't think that works. I think we yeah. Mm-hmm. Mm-hmm. Yeah. I must say,
don't lecture the children, like they say.
Sometimes it's difficult, because if your child doesn't eat the vegetables and says no to the beans and still eats the chips or yeah, but it's yeah. I must feel.
We will keep watching for and looking for the answers once you reach for solving the problem.
Yeah.
Thank you so much, all the speakers. It has been really a privilege and an honor to be with you in the session. I would like to thank again the organizers, Dr. Aisha Al-Dahri and Dr. Layla Sheikh, for an amazing effort, and all the the team behind this. Lastly, there's a request that we take a group photo, if you don't mind.
I feel a bit present in Dubai, I must say. That's like.
By spirit.
And we feel that you are very close to Dubai.
Yeah.
Dr.
How are
Aisha.
you? Yes,
السلام عليكم
أنا
دكتور
دكتور
عائشة.
زكريا وعليكم السلام. كيف الحال دكتورة فاطمة العنوتي، دكتورة سناء،
يا
جميعا.
دكتورة أهلا.
Great. Congratulations, Professor Aisha.
Thank you so
It
much.
was amazing. Wish you
دكتور
all the luck,
محمد
all the
الحليق.
best.
السلام
دكتور
عليكم،
محمد
كيفك
الحليق
دكتورة
وعليكم
ليلى؟
السلام، كيف الحال؟
والله
معك
الحمد
دكتورة
لله.
عايشة. بس حبيت اني انا اشكركم على حضوركم. Thank you so much for your participation, active I would say participation. Thank you for all your efforts. I would like to thank our participants who stayed until this late hours to attend such a wonderful and very informative sessions. I would also like to take this opportunity to thank our moderators, including Dr. Fatma Al-Anouti, for being here and for acting, taking the responsibility of acting like a moderator, because it's not an easy task. Thank you so much. Thank you.
And maybe I leave you.
Thank you, Dr.
Doctora.
Aisha.
I will leave you for the group photo.
Thank you, Dr. Fatma. Thanks to all the professors. I enjoyed being with you.
دكتورة سناء، دكتور محمود، دكتور
أهلين
كيف،
دكتورة
دكتور
ليلى.
زكريا. Thank you so much for the amazing lectures.
I would
and
like
for
to-
being with us.
I would like to say hi to Dr. Mahmoud. I really miss you, Dr. Mahmoud. Dr. Sana. Dr. Sana, I miss you a lot. I haven't seen you for some time.
I miss you too, Allah. We used to meet.
It's a pleasure to meet you, Dr. Fatima, Dr. Keith. And also I can see Dr.
Hopefully
Leila.
next year everyone will see each other.
So thank you all. I appreciate.
Thank you so much.
الله بنشوفكم بدبي عن قريب.
Thank you, everyone.
Inshallah.
Before we end, can I ask everyone to look at your camera on
yes, please, the
so
camera.
that we can take the
camera?
photo? All right, 1, 2, 3, smile. Okay, thank you so much, everyone. Thank you
so much, and have a good night.
Take care, Dr. Sana, Dr.
Have a good night.
Muhammad, Professor
Bye.
Keith.
Bye.
Take care, Dr.
Bye.
Fatma.
Take care. Bye.
Thank you.
السلام عليكم.
All right, to all attendees, thank you so much for staying
Until
with
I
us.
see you, Yakim. Until I see you بعدين.
Thank you to all
السلام
our
عليكم دكتور
attendees.
زكريا.
اهلا وسهلا دكتور محمود، منور، ربنا يخليك.
دكتورة سناء كيف
انا
صحتك؟
سعيده اني شفت حضرتك والدكتور زكريا النهارده.
احنا اسعد الله يخليك.
والله
زكريا شو اخبارك؟
كنت وحشنا. يا رب
يلا ان
نتلاقى
شاء
على
الله
خير ان شاء الله وبصحه.
ان شاء الله باذن الله.
ان شاء الله.
ان شاء الله.
يلا
يلا السلام عليكم.
مع السلامه. مع السلامه.
All right, thank you so much to all our attendees for tonight. Thank you for staying with us at this late hour. We look forward seeing you tomorrow to our third day of the conference. And we hope that you keep on participating on our exhibition booth with all our sponsors for the conference. Please feel free to roam around in the exhibition booth. All sponsors has their chat functionality, which you can ask inquiries or ask clarifications to any of the company's representative. Once again, thank you so much to all our attendees, and see you tomorrow on the same timing on the same link. Have a safe evening, everyone.